All right, to tie everything in, we're going to do a case study. So obviously that's adult learning principles. You learn something, then you apply it to a scenario which is relevant to us. So here's your case study. You're called code 4 for an active fire. A 30-year-old patient was in the house and has sustained third and second degree burns to his hands, his arms, and his upper back. So pretty significant, and a large portion of his body area is burned. So the patient's burns appear a mixture of white, charred, leathery, and some areas have a waxy look. So you can see the kind of mixture of third degree burns and second degree burns, because burns usually occur and kind of manifest with like the bullseye pattern. Then the patient is screaming in pain and he is asking for pain medicine. His GCS 15 has no clinical manifestations of airway burns, so there is no airway compromise. He is normally healthy. He is not on any medications. He has no allergies. So here are the vital signs. Tachycardic at 130. Blood pressure is a little low, 80 on 40. He's breathing about 28 breaths per minute. Lungs are clear. Temperature is 36.1. And his pupils are equal-active to light. So how are we going to treat this patient? Let's delve into it. If we look at the patient's injuries, burns is one of the most excruciating things someone can experience. It all depends on the burn depth, the burn size, and individual variation. Because the deeper the burns, often more nerve damage, and that can lead to more intensity of the pain and prolongation of the pain. And if you look at the burn size, of course, if you have a large proportion of your body burned, that generally leads to increased pain due to the increased area of the tissue damage and inflammation. And just overall individual variability. It's how's your pain perception? It varies from person to person, and that can all be dependent on genetics, previous experiences, and psychological factors. And if we look, so if this has never happened to you, this is a good analogy. If you put your hand on the hot stove, immediately you rip your hand away because it's trying to prevent further and subsequent damage. That's because the nociceptors, or the pain receptors, are responding to that. You get this activation in such a rapid amount of time that sends the signals up the spinal cord to the brain to say this person's in pain, there's ensuing damage, and we need to stop this stimulation from happening to overall mitigate the damage. If we apply what we're going to do for this patient, first, fentanyl is probably best for this patient. It's fast acting, doesn't last that long, and they are hypotensive. And again, to apply the removal of the blood pressure parameter, we can give fentanyl for somebody with hypotension now that is in severe pain. Because of the dosages we give, if we slow push, do aliquots, we can lead to sufficient amounts of analgesia and overall mitigate any cardiovascular effects. Because again, it doesn't usually release large percentage of histamine like morphine. It's not vasoactive like morphine unless you do anesthetic dosages fast push. Ketamine's a very good analgesic medication, especially when combined with an opiate, so that multimodal approach again. But there is a lot of good empirical evidence to suggest its utility in burn patients. So the best thing about this medical directive is ACPs can choose when they can give ketamine, how much ketamine they're giving, whether they switch back to fentanyl. Because if we look, it's always based on your last drug of your interval. We don't give the drug simultaneously. You don't say, here's some fentanyl, here's some ketamine, have fun. No, you let one peak, then you top it up with another. So if you look, you could start with 25 to 75 micrograms of fentanyl. You can pick the dose depending on the patient's pain, their size, their blood pressure, what they're experiencing, and overall you just do aliquot dosages of it. We know that fentanyl is pretty fast acting, and that's why the dosing interval is 5 minutes. So at that point, you can decide to either give more fentanyl or you can jump to ketamine. Because again, when ketamine is combined with an opiate, it leads to opiate sparing effects. Overall, that means I achieve higher amounts of analgesia and I give less drugs overall because I have these two drugs with two different mechanisms that are complementary to one another. So you can decide to give ketamine at this point. This patient's approximately 80 kilos, and if we establish an IV, we can do 20 milligrams of ketamine, or 0.25 milligrams per kilogram. And under our concentration, that's 0.4 mils of a 50 milligram in 1 mil. So to review the different ways you can draw it up, there's multiple different ways. And again, use the dosing chart. This is the patient's weight, this is the volume, this is the milligrams, and below it all, we show you how to draw it up for that safe medication practices. There is no ego in medication practices. Always confirm your dose, always draw it up and confirm it multiple times. I personally like the 1 ml syringe. It's this very visual cue to say it's a very small dose. So I drop 0.4 mils, which is 20 milligrams. I have my dose here, and I drop the rest with saline. Because we always should dilute intravenous meds to mitigate the side effects. Because if you push ketamine quickly, that can lead to adverse events. However, we'll be abundantly clear, it's unlikely side effects will occur at the dosages we give, and especially we can reduce the chances if we push it over to 2 to 3 minutes. So if you drop 0.4 mils of ketamine, which is 20 milligrams, and 0.6 of normal saline, and you push it over 2 to 3 minutes, that's a very safe and effective dose, and you reduce the likelihood of side effects from occurring. However, if we look at the human factors, how often do healthcare providers push meds slow push? Especially if it's busy, especially if they're screaming at you. You can see how this all perpetuates and increases the likelihood of you pushing it quick. So there's 2 more ways you could do it by the intravenous route. You take a 10 cc syringe. So we know our current concentration, unless services decide to get a smaller concentration, you have 50 milligrams per mil. So if I draw up 2 mils of ketamine in a 10 cc syringe, you now have 100 milligrams. You always fill up the syringe with the med first so it's accurate and precise. Afterwards, you do 8 mils of normal saline. So you have a 10 mil solution now. You have 100 milligrams in 10 mils. Or you have 10 milligrams per mil. So if you know your dose is going to be 20 milligrams, you can waste 8 mils so you make sure you don't inadvertently overdose them. So this is precise and it's safe. Then you just administer that amount of volume, which is 2 mils or 20 milligrams, in or over 2 to 3 minutes. Might be hard at that volume, but you can do that. Another way, which again is less safe because you have the potential to overdose them, is that you don't waste the 8 ml syringe and you just push 2 milliliters that way. However, the former way is more reliable, safe, and precise. Another way you could do it as well is that you drop 1 mil of a 50 milligram per 1 mil solution of ketamine. You drop the rest with saline, which is 9 cc's, and now you have 50 milligrams in 10 mils, or you have 5 milligrams per mil. Then you do 4 mils, which is 20 milligrams. You have multiple different narcotics, especially if we're doing this multimodal approach for analgesia. I can give morphine or fentanyl in the circumstance and ketamine. You can have different syringes that kind of look the same so you can see how you can mistakenly give the wrong med or mistake the dosages. The days of putting pink tape and putting little scratches of what med is on is probably not ideal anymore. Some services already have the stickers that are very cost effective, very cheap. You can even make some to say this one's fentanyl, this one's morphine, this one's ketamine. So there is no mistake to what syringe you're giving and when. Overall, this patient can receive fentanyl because they're hypotensive and it's an exceptional analgesic medication. You do aliquot dosages to overall mitigate the hypotension and the respiratory depression. We give ketamine because this patient's in excruciating pain. Burns is the worst pain you can ever experience in your life. And when ketamine's combined with an opiate, it overall leads to opiate-sparing effects. I achieve higher analgesic effects, and I give less drugs overall because they're both complementary and synergistic. So ketamine can increase the patient's blood pressure as well from the release of norepi and epinephrine. And overall, when you decide to integrate ketamine, it's all depending on the patient, if they're unresponsive to fentanyl, if you think they've received an adequate dose, or how severe their pain is, or if you think they could benefit from the surge of catecholamines from ketamine to increase their blood pressure while doing fluid bolus and other therapies as well. If we're doing the intranasal route, again, it's 1 mil max per nair per dose, and we do have to count the 0.12 mils to account for the dead space in the atomizer, but just make it easy. Drop more than you need, put the atomizer on, and zero it out. So that's how you can do it. And anyone 75 kilos and up should receive the max dose of 75 milligrams because it's 1 milligram per mil, and we do not need to dilute anything intranasal. It's just we dilute intravenous to make sure it's precise It's the accurate dose, and it's given very slowly to reduce the side effects. So to tie everything in, we initially gave the patient fentanyl. Then we moved on to ketamine 5 minutes after that because fentanyl is so fast acting, and it's always based on the last medication you administered and their dosing interval. So the second drug we gave was ketamine. However, the next drug we can give, which can either be fentanyl or ketamine depending on the patient, their circumstances, how they respond to the last dose, and a multitude of different factors. We wait 15 minutes because it takes about 15 minutes on average for ketamine to peak. So that's why the next dose will be 15 minutes later.